Thank you so much for this opportunity. Sarah and Camille and I are really passionate about this project and super excited to talk to you about it today. My name's Kim. I'm a spiritual health practitioner in critical care at St. Paul's Hospital in downtown Vancouver. Sarah Ho is a social worker for Providence Healthcare, and Camille Ricketts is a critical care nurse at St. Paul's Hospital as well. And before we start, the three of us would like to acknowledge that we are presenting from the traditional ancestral unceded lands of the Musqueam, Squamish, and Tsleil-Waututh. And we give thanks to them for their generosity, and we commit to continuing to pursue truth and reconciliation in our work. Just a little roadmap for today. We'll start off with Sarah giving the background as well as how we got this project, or she got this project off the ground. And then I'll talk a bit about how we support and equip our facilitators for family presence during resuscitation. Camille will walk through the things that came up as we implemented family presence during resuscitation, and how we continued to improve, hopefully. I will talk through the challenges that inevitably came up, and then Camille will finish us off by talking about how we move forward from where we are now. So I will gladly hand it over to Sarah.
All right, thank you, Kim. So I wanted to start by sharing a story. So I hope that you can just try to picture yourself there. Patient Mrs. S is a 67-year-old woman who was brought to St. Paul's Hospital by EHS alongside her spouse, Mr. S. EHS had arrived at the home and she'd required immediate resuscitation, which they'd been actively working on during transport to emergency. Upon arriving at St. Paul's, she was taken to the trauma bay and staff had taken Mr. S aside before he could enter the room. Mr. S informed social work that they have a strong religious belief that Mr. S needed to be present when Mrs. S's soul left her body, and that Mr. S desperately needed to be with her. The social worker liaised with the ER physician, who conveyed he just needed a few minutes to assess the situation before allowing the husband to enter. Unfortunately, those few minutes were the last minutes of the patient's life. So while the names and identifying information were changed, this is basically an incident that happened about 2 years ago, and it is what kicked off the restart of our knowledge translation project. We really did not want this situation to happen again, where a family member was denied the opportunity to be with their loved one in the final moments of their life. Just to give you some more background, I was the social worker in the ICU at St. Paul's for many years, since 2011, and family presence during resuscitation was first brought to my attention back in 2014. I started working on a practice guideline for social workers on responding to code blues, and then the social work site lead at the time approached me about applying for a KT challenge, which we ended up receiving funding for in 2018. There had been a recommendation at the time to focus on the ER and ICU only initially. And so I had been meeting with the social workers in those areas to gauge their experience and comfort level with this and let them know what the research and best practices were. Unfortunately, in 2019, the social work site lead, who was the lead on the project, moved to a different role. And then I started my maternity leave, and then COVID hit. And so our project was placed on the back burner. Partly because of the education that had already been provided to our social workers, family presence was being practiced at times, but we had not managed to formalize any policy or guidelines on this. And as part of our learning from the incident, it was identified that having something formal regarding our organization's stance on FPDR would have been helpful to prevent a similar situation from happening again. So even though now I work on the other end of the spectrum of acute care, I do care planning for patients that don't actually need to be coming to the hospital. because of the work I had started on this all those years ago, I was asked to take the lead on applying to start our KT Challenge again. So what do we mean when we say FPDR? So we use FPDR as an acronym for our project just because it's easier to say. And as we mentioned, it stands for Family Presence During Resuscitation. But really our project was more around creating a framework for how we support family members during resuscitation attempts, wherever they are, at the bedside, in the hospital, somewhere miles away. We wanted to make sure that they are supported throughout the process, and that includes being assessed for appropriateness for being at the bedside, that we are offering them the option to be present at the bedside, and that a trained facilitator is with them at all times, especially if they are at the bedside. And you also see it mentioned in the research as family witness resuscitation, or FWR. So we wanted to briefly touch on the research basis for this. There's been research being completed for over 30 years now. And generally, the clinicians worry about it causing trauma or negative effects on the family, on the effects on patient outcomes and performance, that there will be disruptions or distractions, and legal action or consequences. And the research says that the concerns are really not substantiated, and that FPDR increases family trust and satisfaction, that family members may have better psychological outcomes. It helps with the grieving process, closure. It decreases their fear and anxiety. It dispels helplessness, wondering, and dread of the unknown. Patients are comforted by having their family members present. They feel safer, less scared, supported. It may reduce stress and anxiety. It also facilitates communication and collaboration between the team and with the family, and it reinforces that staff tried their best. Family members really feel that this is a right, not a privilege. And the general conclusion is that the benefits outweigh the risks. So despite that this is an Accreditation Canada standard, and it's supported by many societies and associations like the Canadian Critical Care Society, the Society for Critical Care Medicine, Emergency Nursing Association, amongst others, there's still a lack of consistency in offering this. And so we wanted to develop a guideline to offer FPDR systematically. Okay, so as mentioned earlier, this was initially planned to be a pilot in the ER and ICU. So when I started to try to form our KT Challenge group, I approached the staff in both of these areas at St. Paul's Hospital and Mount St. Joseph's Hospital, which are the two acute care hospitals under Providence Healthcare, to see if anyone was interested in being part of our group. As you can see in the list here, we had a number of different representatives from different areas. So a bunch of nurses, clinical nurse educator, nurse specialist, CNL, and Camille, our bedside nurse. We had a whole bunch of social workers too, the site lead for Mount St. Joe's, and who is also the research and education coordinator. And then from the ER and ICU at both sites. And we had spiritual care, a physician, and two patient and family partners. And we started monthly meetings to plan for our next steps. So our kind of first main thing that we worked on was stakeholder engagement, to try to gauge the attitudes of the staff, and just to provide information and find out what further education and engagement was needed. Yeah, so as you can see in the list here, there's a whole bunch of different staff that we met with, and it's probably not an exhaustive list here, but just to give you an idea of the range of roles that are affected by this practice change. So we met with social workers, spiritual care, Indigenous wellness liaisons, physician groups, CNLs, critical care nurse educators, clinical site coordinators, security and relational security officers, respiratory therapists, simulation operations. We attended cardiac arrest committee meetings. We met with professional practice, the vice president of medical affairs and quality and safety, and attended various care team meetings. Generally, we found people were really on board with this initiative. And so as we began speaking more about our project, we were also hearing more instances where families were being offered the opportunity to witness their loved one's resuscitation. Because our initial plan had been to pilot this in the ER and ICU, we initially had focused on these areas only. But because the social workers in the ER and ICU are the ones responding to all codes on weekends and after hours, we started seeing this being offered in other areas of the hospital as well. We actually were able to support a family member to be present during a resuscitation in the cath lab that occurred after hours. And so because this was already starting to happen more often throughout the hospital, it was recommended by professional practice that we would roll out across the acute care sites rather than only in specific areas. So we had even more meetings with more people. We met with CNLs and CNEs before the rollout, and then we continued to meet with the groups and attend various care team meetings as we went along and as issues arose. And we just wanted to really highlight that stakeholder engagement is really an ongoing process, and we continue to loop in with people and just connect just as needed. All right. So then what we were doing simultaneously was creating a decision support tool. So as I had mentioned, I'd already had a draft practice guideline called Social Work Response to Code Blues, and that had been put together based on reviewing all of the research that on this. And I'd also received a lot of information and resources from the University of Washington Medical Center and Alberta Health Services, who have had policies on this for many years. So we completed a new literature review 2 years ago, and then we incorporated the recent research into an updated DST. So at our organization, Spiritual Care has always responded to Code Blues, and so they were listed as equal facilitators to social workers. And it was actually one of our patient family partners that really pushed us to engage the Indigenous wellness liaisons to also be equal facilitators. So we met with them, their input, and incorporated their role as facilitators too. So it went from being a social work practice guideline into an interdisciplinary decision support tool. And our DST, this is just like a screenshot kind of what it looks like, but it has a step-by-step procedure on what to do when a code blue is called. There's a flow chart, a family support handout, which lists typical reactions family members may have, signs of the reaction, and practical assistance that can be provided, and also includes a sample script for facilitators to give an example of what to say when approaching family members, informing them of their options, preparing them for what to expect, providing ground rules, and alerting the code team of their arrival. And our DST was sent out to various stakeholders for review before we submitted it to professional practice. And they also sent it out to a number of stakeholders prior to it being approved. And now I will pass it on to Kim, who will be talking about equipping our facilitators.
Thanks, Sarah. So Sarah's covered a bit of just the general idea of family presence during resuscitation and the pieces that go into it. And I want to zoom in here on the role of the facilitator themselves. So as Sarah said, it's typically going to be the social worker or a spiritual health practitioner like myself. And when needed, we will call upon one of our Indigenous wellness liaisons to be present with family and loved ones. But this is during business hours, I should point that out. And we are now also trying to encourage a number of our nurses and charge nurses, nursing leads to take our training, which I'll talk about in a minute, so that they too can feel equipped and ready to provide presence when spiritual health or the emergency social worker, et cetera, can't be present there. In our policy, it says that the family facilitator will coordinate a plan to support families during codes, including support for the family to be present during resuscitation attempts when appropriate. And so the facilitator, their role is to arrive, assess the situation, find anyone that requires that presence, and then we have that beautiful flow chart that was created to help create that step-by-step process of what needs to happen next. How can I, if they want, how can I escort this person into the room, so on and so forth. And then further, our policy says, and this is so key, understanding that family presence should be offered by default. The facilitator will confirm with the code team that family presence during the code is an option. So as I think Sarah said earlier, this is not for exceptional circumstances. This is for all circumstances unless there is something exceptional, meaning that the family or loved ones can't be in the room. And really what is meant by this is that our intention should always be to include the family. Our intention and desire will keep them at the center, and remember that they too, in many ways, are a part of the care team for that patient, and that their presence is important, not just for that family member themselves, but also for the patient in the room. And I didn't say this earlier, but obviously there will be time for questions at the end, and I hope that you're holding on to those treasures and we'll get to address them. But I think we would also love to hear any stories. I think that's where we really understand how these things play out. And if you want to hear any stories from our perspective, from our learning, we would be glad to share those as well. So as I said, the facilitator will approach the scene, will assess what is needed, ask the appropriate questions to the family, and if they want, then they will escort them into the room, into that space, hopefully find a corner, a place within eyesight that's not within the team's way, but is still close enough to see what's going on. That facilitator will translate, so to speak, what they are seeing within their scope and abilities, or perhaps be able to drag someone over who can more appropriately translate. And then importantly, ensure that family doesn't interfere with resuscitation efforts in any way. The main purpose and role of the facilitator, it's not to be a babysitter, it's to be kind of an eye in the storm, to give that grounding presence and to help build that trust with the team, and to, again, include the loved ones in the care of their person. So that's not much to ask, right? It's important we recognize that we don't just throw facilitators in without properly equipping them. And so we've been able to put together an online workshop on our Learning Hub. It's 4 videos, about a little less than 2 hours in total, so it's not too much of an ask for people to take this. It covers the background and the research, which will hopefully give some buy-in to those who are taking the workshop. It explains, again, as I just did, the role of the facilitator. And we had one of our ICU nurse educators go through the steps and processes, things that one might see during a code blue, just so that that process isn't foreign to the facilitator, but they can know a little more of what to expect and help the loved one know what to expect as well. And we talk about mindfulness and grounding and being able to still yourself and ground yourself before entering into this chaotic situation so that they can, again, be that eye in the storm. And then we talk through ways to honor and move through the event after it's done so that we can ensure that we have whole and healthy people and that we're not just slowly chipping away at someone's psyche after going through these difficult experiences. And I think evaluated experience will always be the best teacher. And so we are working on having good opportunities for debrief and talking through each instance of FPDR. So Camille, I will give it to you now.
Thanks, Kim. So after and during the teaching process, like Kim mentioned, we also work towards adjusting the Code Blue response as a whole in order to embed FPDR more routinely into our code practices. And so I'm a bedside RN and a member of the code team, and adjusting our response was crucial to gain stakeholder engagement of those involved in the code. So in order to fully integrate FPDR into clinical practice, we recognize the need to revise our Code Blue documentation to track key family-related actions. So this is into our paper and at CST documentation. We added some boxes as was the family involved or was a family notified, were they present, and who supported them? And by creating this structured approach, it made the practice more visible and measurable. And it also enhanced our consistency with FPDR documentation. Oh, somebody's talking. Sorry. It also enhanced our consistency with FPDR documentation and allowed us to track FPDR implementation. And as Sarah and Kim have said, we've formalized the family facilitator role, which is usually social work, Indigenous wellness, or spiritual health teams. And this is part of our new standard Code Blue response. And their role is to identify, reach out, and support family members during the event. And during each Code Blue response, and this is specifically at SPH, we typically have 2 to 3 critical care RNs, a clinical nurse leader, and physicians regularly responding to codes. And they've been now specifically educated on the necessity of contacting family early and supporting the facilitator role. This involves ensuring adequate space adjacent to the resuscitation area to allow for family presence and ensuring family is not escorted out of the room immediately. And by embedding this expectation into our routine practice, we're reinforcing that FPDR is a team responsibility and not an optional extra. And after the code event, then team members are expected to document family involvement in both the Code Blue record and in the patient chart. And all of these steps, I mean, while they seem kind of just like paperwork, they actually really help ensure that family presence during resuscitation is not only supported, but operationalized and sustained as part of our standard critical care. So going into that, this is kind of how we shifted the culture and normalized family presence. So shifting the culture around FPDR meant moving beyond individual attitudes to a more collective understanding that family presence can be safe, supported, and beneficial. And we've prioritized education and open dialogue to address common concerns. And those concerns, like Sarah mentioned, fear of distraction, trauma, or legal risk, with more research and real examples of how it's beneficial. And by integrating FPDR into simulations and debriefings, we help normalize it as part of routine part of critical care and in general care and all codes, and not just a special exception. And I think a key takeaway for us is that our work is really interdisciplinary. Nurses, physicians, social workers, Indigenous wellness liaisons, spiritual care practitioners will all play a role in supporting families and one another in these process. And also, we found that sharing early successes and family stories has been key to building confidence and momentum in the team and just in the culture in general. And lastly, we just want to make sure that we're fostering psychological safety, like Kim mentioned in the teaching, and making space for staff to ask questions about it, to reflect and kind of grow together as this practice evolves. And so kind of just to quantify and look at the data, we did some chart reviews from July 2024 to February this year. And overall in this period, we reviewed charts in order to evaluate early outcomes related to family presence during resuscitation. And a major limiting factor I think we found overall was that many patients didn't have family members available to contact if needed. And it wasn't necessarily that family presence was refused, but additionally, the number of true active resuscitation codes was at relatively low for our hospital. Many codes were shorter and less complex events, reducing the opportunities to practice full FPDR protocols. But despite this, we have seen a rise in documentation from social work and spiritual care indicating increasing family support when possible. And we started, when we started this in the summer, there were almost no notes regarding family support during codes, and now we're seeing this documented more consistently. And I think these findings kind of suggest these early cultural shifts towards supporting families, even if there's limited opportunities to do so. And I think continued data collection and monitoring will be essential to guide education and policy as we embed this more into our practice. And so this is just some data that we have from St. Paul's Hospital Code Blue records, and it's displayed graphically for the instances of family supported since starting the project. Unfortunately, this doesn't have the data from the ER or MSJ codes because those aren't documented in our same Code Blue records. But as you can see, we haven't had that many codes, but despite this, it does show progression and a more positive shift towards more support for families since implementation. And so I'll pass it back to Kim to talk about some of our challenges we had.
Thanks, Camille. Yeah, it wouldn't be a fulsome sort of review of our project without addressing the challenges that we encountered. And so we know that a lot of good learning comes through any type of adversity when worked through well. So I think it's important that we talk about these. So starting at the top, one of our first big challenges was just the leadership change. Our initial project lead, Sarah, as she said, transitioned out of the ICU early on and wasn't exactly on the front lines anymore. And so that just made championing the concept and spreading the word, maintaining the presence on the floor for this practice made it a little more difficult. A big challenge that we have encountered is this variation in clinical judgment. So while there was quite a lot of enthusiasm for FPDR in the early stages, kind of once we put it into practice, we encountered some tension around when is it actually appropriate to allow the family to be in the room. And really this comes down to clinical judgment, which could differ between the facilitator and the code team of what is actually appropriate. So appropriate is a bit of a vague, broad word, and we're still working that out, but key to addressing this challenge is keeping open the channels of communication and not getting discouraged when there are these disagreements, but knowing that it's an opportunity. Furthermore, Camille talked a bit about this, just having to work on that culture change because we have encountered some cultural resistance. It's been talked about as sort of the old school approach because in many cases, the codes are bloody, chaotic, and those situations in the old school mindset are seen as inappropriate for families. But Sarah already mentioned that the overwhelming evidence is that families can benefit even under those circumstances. And maybe to put it this way, I'm a big fan of the horror genre, and I guarantee that what you can't see, what you don't see, is far worse than what you do see a lot of times, because the mind will fill in the blanks and there will be a lot more questions than answers. But again, back to that old school understanding, I don't hear this talked about a lot, but what we've moved away from in the last decade to 20 years is this very paternalistic approach to medicine, in which the physician or the healthcare team is responsible for protecting and keeping at a distance people from these difficult circumstances. And as I also said earlier, what we are trying to shift the culture to is that family are a part of the care. And that's incredibly important, but we still meet with the resistance. And there's a lot of things too. It could be old school mindset. It can also be, this is a new doctor, a resident, and absolutely no judgment to the fact that that is incredibly nerve-wracking to imagine a loved one of someone whose life you're trying to save standing there in the room looking at your every move. So again, communication, working through the questions and the fears of the healthcare providers and addressing those one by one as they come up. Sort of said this earlier, but more staff support FPDR in theory than in like practical ways. The hesitation, as soon as it gets intense, the hesitation can skyrocket. And that comes down to needing to trust the facilitator's judgment. And sort of embedded in this challenge that we've discovered is so I'm the spiritual health practitioner for our intensive care unit where our code team comes from. And so they're familiar with me. And so there's sort of that built-in trust between us. But when I've gone to some other areas where, like Emerge or perhaps our cardiac units where the code team from ICU may not go, but it's their specific teams that deal with it, they don't know me. And so then there's the question of like, how can I trust your judgment to know that this is appropriate? So again, we have to just work these things out. The physical space is a big challenge for us. St. Paul's has small rooms. Sometimes there are 4 people to a room and you're dealing with one tiny corner. So figuring out how to facilitate this presence when there's 12 other people needing to be there at the bedside, that's a challenge that we're still working through. And finally, high staff turnover. The reality is we get people moving to different wards, to different hospitals. And so ongoing education is needed and vital to continue to embed the practice across acute care. And I will give it back to Camille now.
Hi, thanks. So just to kind of wrap up, this is just where we are moving forward with our project and kind of how we're going to sustain and integrate FPDR moving forward. So like we talked about stakeholder engagement being really important, we recognize that sustainability starts with embedding FPDR into existing structures. And to do this, we're meeting with the Cardiac Arrest Committee to align FPDR with Code Blue processes and decision making. Our ICU social work and spiritual health practitioners, and I think we're going to branch out of just ICU, but they will now be invited to attend these meetings more regularly, ensuring psychosocial support is integrated from the beginning. And we're also embedding this into practice, like I said before. One of the strongest ways to normalize FPDR is through simulation. So we've now started incorporating it into all the mock codes to practice both clinical and communication skills in real time. And this will involve the facilitator role in all mock code blues moving forward. And as a bedside RN, this will be really important because that physical space limitation, I think there's lots of concerns about that as bedside practice, and it will kind of be able to allow us to test and see where the facilitator can come, where they can be positioned in the room so that they're, out of the way, but still present. So that's really important for the simulation. Like I said before, also, we're continuing to work on our Code Blue record format, and this will allow for us to have more consistent documentation and reporting so that each FPDR event becomes part of the continuous quality improvement process. And like we said, this is an ongoing process with continuous review and adjustment for new areas around the hospital. For example, we have to design the FPDR to the ER workflow And this is the entire premise of the knowledge to action framework, which is kind of what we base this on, and which is the continual implementation and adjustment for new areas around the hospital. And so the last kind of two pieces moving forward, like we said before, education and cultural shift. We know that education isn't just a one-time process. Ongoing refreshers and case reviews and resource sharing will help reinforce FPDR as a core practice rather than as an exception. And like we said before, we need to trust facilitators with these decisions, and therefore ongoing education about this project and clinical judgment will need to continue. We're also encouraging reflective debriefs after resuscitation events, and these will help the team process their experiences and identify what went well or where more support is needed for the family. And then for disseminating this information, kind of to contribute to the broader practice change, we are preparing to submit this KT Challenge project for publication. We're considering several venues, including the Canadian Critical Care Nursing Journal, which has a KT specific focus and publishes online. Also considering the Critical Care Nursing Journal or the Patient Voices Network. Additionally, the EHS has reached out to us to collaborate, and so we're also exploring the possibility of influencing updates to the first responder guidelines by proposing the inclusion of family presence during resuscitation as a recognized supported practice. And then lastly, we will be presenting our work at the World Congress of Intensive Care in 2025. This will be in Vancouver in September. And this is an exciting opportunity to share our process, connect with international colleagues, and then we can learn from others if there's similar initiatives in other areas of critical care or around hospitals. And yeah, that is our presentation. If anyone has any questions, we also have a reference slide as well, but we'll open it up for questions at this point.
Thanks so much to all three of you. That is fantastic work that you've done. And Sarah, I know you've been working on this for a very, very long time. So it's nice to have some consistency through it and see it grow to be as big as it is. And I think that's fantastic that BC EHS has reached out to you for support that way. That's an avenue that I hadn't really thought of before that I could see being very, very beneficial. So congratulations on that. Does anybody have any questions for the group?
Questions or stories? I mean,
or stories, yeah, exactly.
There's so much wisdom to share all around, I'm sure, in this room. Oh, we've stunned them to silence.
Tracy, go ahead.
Hey, can you hear me? My mute's been weird today.
Yeah,
okay, awesome. So thank you so much. This is such amazing work. And in Interior Health, we've been talking about developing something like this for some time and just haven't been able to get traction. It's actually one of our big rocks. I'm hoping to get it approved as one of our rocks for this year. So I'm super excited about all the great work you guys have done because I don't have to start at the beginning. I can build off of some of the great work that you guys have done. So thank you. I will say in my experience, it is already happening informally, but there's still, like you identified in your presentation, a lot of varying thoughts and practices. So it's quite where we've had family be present and we've had that individual there to support them in answering questions and such, that it's always a great experience. I haven't personally had a bad experience. It's always been really great. And I feel that most of our experiences that are bad is when family isn't included. So I just think it's so wonderful. And I hope that we have the success that you guys have. So thank you so much for sharing today.
I think something you said during the presentation, Kim, really stuck out for me, that when families don't see their imagination goes crazy, right? So as soon as you bring them in, the questions are, well, many of the questions anyways are answered. Like they can see what's happening with their family member. I do remember one situation that I think of sometimes when this conversation comes up. A patient long time ago, was long time in the ICU, months, I think, and lots of family presence continuously. And she ended up, coding on the floor, and the family didn't want to come in at first. And the code went on and it went on and on. And then the family finally were like, yeah, I'll come in. And as soon as they came in, they're like, I get it. They could see, probably like 15 people around the bed trying to save their loved one's life. And I think, like, what could have happened, or how could that have been better if the family was there right from the beginning? I think about that case a lot sometimes.
Yeah, exactly. And I think, sorry, I'll let you go after this, Sarah. I think about our Indigenous patients who, so many of them have histories of trauma in the healthcare system and an understandable distrust in the healthcare system. And so to ensure that they are there to see that everything is being done, I think while there's inevitable trauma and grief, right, to losing someone, I would hope that that is part of our needed work in rebuilding that trust that's been lost.
Yeah, definitely, Kim. The family I talked about was Indigenous as well, so those issues included, right? Yeah. Go ahead, Sarah.
Yes, I just was gonna mention that's one of the things that was brought up in some of the research, was that when the family members are there and actually seeing what their loved one is going through, that they at times will actually ask to stop the code earlier because they see like the breaking of the ribs and all that, and like and it's like, this isn't actually what they would want, right? And then I think one other thing that I think we just forgot to mention was that when we bring the family members in, they're always welcome to leave and come and go. And it's not like, oh, once you're there, you have to stay, right? That's just a continual assessment of their comfort level, and making sure that they're aware of that too, that, if they go in and they don't want to see anymore, we can bring them right back out.
I was also just going to add to what we were saying earlier as well. Just from like the bedside perspective, it's really helpful to have the facilitator there, because we want the critical, like the nurses that are doing the code, to feel like they can just fully focus on the code and not feel pulled by family like outside and feeling like you're in between. So it's really comforting as an RN to have the facilitator role there and know that the family is supported and being explained the process of the code without having to jump into the code and then jump back and speak to the family. It seems a lot more calm and supported, and having like that structure in place is super helpful as like a bedside RN in a code situation.
And the resources you talked about on Learning Hub, like even just I think it was a video of what the code process is, or discussion about that. I was thinking that would be really fantastic, even for new to critical care nurses, to have a look at, because sometimes we're not prepared for what a code actually looks like in critical care, right? Like before some of the RNs get through critical care training and they're having codes on the floor. Often it's like the code team comes and kind of takes over, but to see that from a different perspective of you being like there at the bedside, and I'm sure quite valuable for social work or anybody around to have a look at, so they know they can prepare themselves for that before they get to that situation. Excellent work, team. Thank you very much for coming to share your story and your work with us, and I look forward to seeing your presentation at World Congress in September. Congratulations on being accepted for that. That's great to be able to share this work with the world, really, which is pretty cool.
Thank you so much.
Thank you.
Okay. Yeah, great.
Thank you.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content from previous events we've had over the past 12 months. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.